Thank you, Sunil, and thank you for the opportunity. Yeah, it's Code, difficult to pronounce. That's why I write it specifically that way. So, anyway, what we're going to discuss, this abstract was presented in ESMO 2021, and it's from Japan, and it looked at a comparison of osimertinib plus bevacizumab versus osimertinib monotherapy in patients with non-squamous lung cancer with EGFR mutations. So this was a phase 2 study, and we know that osimertinib now has become the gold standard according to the FLORA trial in first-line treatment of EGFR mutated lung cancer. And there has been studies telling that the addition of a VEGF inhibitor to TKI is better than using TKI alone, but this is mostly in the first generation TKIs. We do not know the answer with third generation TKIs. So this phase 2 trial was set up to do this. So this was the study design, and they included patients with non-squamous, non-small cell lung cancer with EGFR activating mutations 19 and 21. And they included stages from stage 3B to 4, and the rest is routine. They excluded patients who had symptomatic brain metastasis. So there are a total of 122 patients, and they were randomized 1:1 into osimertinib plus Bev versus osimertinib alone. And Bev was given at 15 milligram per kg, and this was continued till progression. The primary endpoint, as this was a phase 2 trial, was progression-free survival by the blinded independent review. And patients were stratified based on their sex, on their stage, and what kind of mutation they had. So the statistical consideration in this was that we know osimertinib has a PFS of around 18 months. Addition of bevacizumab would increase this to 27 months. Now, that was the statistical consideration. So the trial was prepared in this way. So this is a consort diagram where the patients were randomized, 61 in one arm, 61, and also 61 in the other arm as well. And the baseline characteristics were more or less well balanced. A significant proportion, I'd say around 50% in the osimertinib monotherapy arm, were ever smokers, patients who had a history of smoking. And it was only 37% in the osimertinib plus Bev arm. So a slight mismatch there, but this tells you that a significant number of smokers were there. Other than that, the EGFR mutation was fairly well balanced, 60% versus 40%, like in clinical practice. So this was the primary endpoint, and the primary endpoint, which was PFS in the whole population, was not significant. So this was a negative trial. The addition of bevacizumab to osimertinib did not improve the progression-free survival compared to osimertinib alone. The median PFS was 20 months in the monotherapy arm versus 22 months in the Bev arm. The difference not statistically significant. The secondary endpoint was the PFS assessed by investigators, and this again also was not statistically significant, 17 months versus 24 months. Moving on to various subgroup analysis, again, you can see it's scattered in both sides across the chart. So there's neither one group doing much better than the other, except for if you look really carefully, you can see that exon 19 may be doing slightly better, and also patients who were smokers, ever smokers, they had a slightly better advantage. But this is again, this subgroup analysis, small numbers. So because this was, a sponsored trial, we had to look at further details, look at specific subgroups who would benefit. And one of the subgroups were ever smokers, where OC plus Bev had a slightly better advantage compared to osimertinib alone. In never smokers, the difference was not significant. And if you look at the PFS by EGFR mutation status, exon 19 mutations did slightly better hazard ratios, where exon 21 had not much of differences. Again, these are subgroup analysis with numbers to less than 40 patients. So this is just, as they say, hypothesis generating. The response rates are more or less balanced in both arms, 86 versus 82%. 1% had complete response when we used Bev. And the final overall survival, this was immediate, but secondary endpoint. But again, as you can see, the curves are all over each other. There is no difference in overall survival as well, which was not reached in both arms. Safety of the combination, if you're using osimertinib plus Bev, you had more discontinuation, almost double the discontinuation of using osimertinib alone. Severe side effects in 11% versus 5%, and death was not seen or reported in this trial. If you look at the most common adverse events, we know that diarrhea, paronychia, and mucositis are going to be there in both arms because of osimertinib. Pneumonitis is something surprising. What was found, 18% had pneumonitis in the monotherapy arm, but when you use bevacizumab along with osimertinib, the number was only 3.3%. So does bevacizumab actually reduce the chances of pneumonitis? That's a question that needs answering. The BEV-induced toxicity of hypertension, epistaxis, and proteinuria was significantly more in the experimental arm as well. So the final summary is that this trial failed to show a benefit of using OC plus BEV when you compare it with osimertinib alone in upfront EGFR mutated patients. The only subgroups were ever smokers or patients who had a deletion exon 19, but again, this is a subgroup analysis of phase 2 trial. In this combination, also might reduce the risk of, as I discussed, the combination of bevacizumab might reduce the risk of pneumonitis. My final take is, would I use this combination? No. The reason I believe is because osimertinib is very good by itself. Bev doesn't add much to the clinical picture. The second point is, which is the extreme rare patient that you could use this, probably somebody who's got interstitial lung disease and you're scared of using osimertinib because of the TKI-induced pneumonitis. You can add Bev for that extra advantage, but again, this is just experimental. It has to be confirmed. Thank you.